Look at this footage. You're moving through a sterile, highly illuminated hospital corridor in the middle of a chaotic emergency response. In scenarios exactly like this, where every second counts, a critical mistake has just occurred. When these adverse medical events happen, the healthcare industry's default reaction is entirely predictable. Committees form, investigations launch, and the obsessive focus narrows down to finding a medical error and pinning individual blame on the clinician who happened to be holding the scalpel or the syringe. The proposed solutions usually attempt to fix what managers call the factors of the human. They send staff to retraining seminars so they can learn to be more careful, or they mandate brief mindfulness courses and team-building exercises, hoping to modify human behavior. But this behavioral approach gets it backward. The true scientific discipline of human factors, also known as ergonomics, does not exist to eliminate human error or fix imperfect people. Trying to engineer a flawless worker is a futile, educationally backward endeavor. Other high-stakes fields recognized this decades ago. The aviation and nuclear power industries embraced true safety science, designing systems that anticipate human limits, while healthcare has been remarkably slow to adopt these exact same methods. As long as healthcare systems try to engineer the perfect human, instead of acknowledging that humans will inevitably make mistakes, they will continue to actively harm both their workforce and the patients they are trying to save. Real human factors is a bridging discipline. Rather than focusing on clinical risk or generic patient safety initiatives that try to change the worker, it takes a holistic, design-driven approach. It looks at the problem and modifies the entire work system to fit the people who operate within it. This animation illustrates the core philosophy of the field, known as the twin aims. You have one shape representing overall system performance, things like efficiency and productivity, and another representing human well-being, such as health and job satisfaction. The goal is to optimize both simultaneously into a single, unified structure. To achieve this, the field is broken down into specific domains. As that core expands into a wireframe grid, we enter the physical domain. This involves redesigning equipment and spatial layouts, measuring lifting angles, and tracking spine stress lines to protect the musculoskeletal health of surgeons, nurses, and porters. The grid then shifts to map out the cognitive domain. Here, the focus is on safeguarding mental well-being by creating intuitive medical device interfaces and logical software architecture, which directly reduces decision fatigue and burnout. Ignoring physical strain leads to injury, and ignoring cognitive overload guarantees mistakes. Because these outcomes are inextricably linked, staff well-being becomes the absolute prerequisite for patient safety. Zooming out from the individual, we reach the third domain, organizational or macro human factors. This area examines the invisible structures and hierarchies of healthcare. Macro design targets the organizational architecture itself. It means restructuring shift patterns, rethinking resource allocation, altering procurement strategies, and rebuilding communication and leadership structures. Watch this network map to see why macro design matters. When a red failure spark, an inevitable human mistake, travels through a well-designed system, it gets safely absorbed and rerouted by multiple redundant pathways. Adverse events are almost never caused by an isolated human failure. They emerge from complex interacting phenomena born from poorly designed workflows and technologies. The objective is to achieve a state known as ALARB, which stands for as low as reasonably practicable. Since you cannot eliminate human error, you build systems so resilient that when those inevitable mistakes happen, their impact is minimized. Recognizing these macro-level interactions shifts the burden of safety. The responsibility moves off the shoulders of the overwhelmed individual clinician and onto the architectural design of the organization itself. Implementing this shift in design requires serious expertise. Because human factors is a rigorous scientific discipline, relying on short weekend training programs or basic simulation exercises is entirely insufficient for creating lasting change. The actual expertise required mirrors the clinical side. Professional ergonomists undergo years of specific training, supervised practice, and continuous professional development. Healthcare leaders can begin this transition by investing in their current workforce. By funding individuals to complete university-level postgraduate distance learning courses, Organizations start the long-term process of building internal expertise from within. Second, organizations need to update their hiring strategies. When a safety team member leaves, stop passively posting generic job listings. Actively advertise for qualified, specialized human factors experts to fill the vacancy. These specialists must also be deployed at the national level. They are needed to oversee healthcare supply procurement, guide new hospital builds, and manage major technology rollouts. When you see a high-quality professional certification document like this, complete with a seal from a chartered ergonomics institute, it means you are looking at a verified expert. Healthcare leaders must verify university degrees and professional memberships, rather than buying in unaccredited consultants who merely claim to know the field. The path to a truly safe healthcare system does not require eliminating human error. It requires hiring the scientific experts who actually know how to design around it.